All right, good.
We started, right?
Yeah.
I'll sit right here.
Yeah, sit next to it. Yeah. Let me know. All right, everybody in? Thank you for the tape.
There is tape actually here. I'm sorry.
No, you cannot. All right, so everybody's familiar with me by now, right? Dr. Karish from so we're going to do a review of the EKG today, okay? Cool, thank you, sir. So what's the first thing you read on EKG? What should you be looking at?
Read rhythm.
Identification, right? You got to make sure that the demographic data you have in front of you and on the EKG is for the right patient, right? Don't go just straight into calling whatever diagnosis you want on EKG. And the second?
Standardized.
Hmm?
The standardized.
Oh, you make sure that the whatever standardization or default setting are there, that you don't overread voltages or duration of the waves, right? Okay. And before you jump into reading and having a systematic approach to EKG, you should ask yourself, as with anything that you order, why did I ask for an EKG, right? So if somebody comes with chest pain, that's going to make sense that you're going to be hunting for ST depression, right? ST elevation, keyword inversions, all sorts of changes that are consistent with ischemia. If somebody comes with syncope, you may want to chase arrhythmias, right? If you're thinking of some paroxysmal event that triggered the syncope, and you want to make sure that this is not paroxysmal AFib or aflutter or whatever. All right, so ask yourself, why did I ask for the EKG? Okay. Then we're just going to run down the waves and sort of figure out what's going on. So the first thing, now that we know, okay, this is our patient, this is why I asked the EKG for, is to look at the EKG and establish rate and rhythm, right? That should be your first rate and rhythm. We'll go about rate because that would be the easiest one to establish, right? All right. So my way of doing it is more than just one way, but I prefer this one, and I'll tell you about this one. You have the big boxes, right, on EKG? How many milliseconds has one big box? Well, one little box is 40 milliseconds. One big box is 200 milliseconds. All right, so the trick is find a sharp wave or R wave or whatever it's very definite to fall on one of those big lines and see where the next will fall, right? You see where the next will fall. And then the rule is this. The first line is 300 BPM, second one is 150, right? 100, 75, 60, 50, and so forth, okay? So this is one of the easiest ways to establish rate, all right? If you have a regular rate, you can call it, all right? So it shouldn't be such a difficult task to establish rate, especially if it's regular, right? You see the big lines, you know the big boxes, and you establish rate. Then the rhythm. The rhythm. Who's usually dictating the rhythm? All right, these are atria, these are ventricles. All right, so who's dictating the rhythm? SA note, right? So SA note, and because it's the most, because it fires at the highest rate, it sort of suppresses anything else that happens around or below, right? So this one, this guy, little guy, he fires at about what rate? Intrinsic rate, automaticity of the signal goes about like around what, 90 to 120, right? And because you have vagus nerve, all right, your usual patient rate is going to be 60 to 110. And that's your normal range. Anything below 60, you're bradycardic. And anything above 110, you're tachycardic. And we'll speak about a couple of situations when you deal with a bradycardic patient and you deal with a tachycardic patient. So to call something sinus rhythm, what do you need? You need P waves followed by QRS, regular aspect, and with an axis that points out the fact that this is coming from above. Very similar to the QRS axis, if you think about it, right? Right? So it should be positive in 1 and APF, right? Because it comes down, comes sort of similar to QRS, all right? So if it walks like a duck and quacks like a duck, it's probably coming from the SA node, all right? And you can call a sinus rhythm. So as long as you have a P followed by QRS and very regular, that's your likely sinus rhythm. So what can happen with the P wave? So we know P wave, because it starts in the right atrium, the first that's going to be depolarized, and I'm just exaggerating things, is going to be the right atrium. And then it's going to be the left atrium. But you're not going to be able to discern this notch here, all right? So there could be a couple of things that can happen. The P wave can be tall, right? Or the P wave can be long. So if it's tall, usually more than 2.5 millimeters in 2, or more than 1.5 in V1, that's a P pulmonale, or the fancy name, dextrocardial, meaning that some pathology is happening in the right heart. So that's a core pulmonale, right? And if it's bifid like this one, you call this P mitral, or sinistrocardial, that's the fancy name for it. And that means something is wrong in the left heart. Classically seen with what? Mitral stenosis, right? So, mitral stenosis, this is P pulmonale, and this is mitral stenosis. How often do you see these guys? You don't really get to see them anymore, okay? Because we treat rheumatic heart disease, right, from the beginning, so you don't get to see it as much. But back in the day, you would see this patient maybe coming up with shortness of breath, heart failure, right? The ready complexion in their cheeks, like the fluffy mitral, and the left atrial enlargement, right? P pulmonale. Classically, you see the people with what? Long-standing COPD, right? Pulmonale, pulmonary hypertension of any cause, whether it's idiopathic or secondary, right? That's your P pulmonale. Another one, we tend to believe that P pulmonale, you see it with core pulmonale, but core pulmonale can be chronic or acute. So what's an instance you have an acute core pulmonale? There you go, okay? So you're going to see anything. So that means you're going to see tachycardia on EKG. The patient's going to be dyspneic. Or not. You have people, old people, even old people with massive P that were not dyspneic or desaturating. But you may be able to see these things on EKG. RVH, right axis deviation, okay? And you may be right bundle as well, along with core pulmonale. Now, what are a couple of situations that you may be able to see bradycardia? Let's put it in context, because just plainly talking about EKG, you'll forget everything. But bradycardia, I mean, there's not like a bunch of things, right? Can make a patient bradycardia. Athletes, that's all right. Athletes will have a good vagal tone, and so they're going to be bradycardia without necessarily meaning anything. What else? You have, let's call it sinus bradycardia. Six sinus syndrome. Okay. What else? Sleep. All right. So in your sleep, your temperature drops, right, and your heart rate drops as well. Hypothyroidism, okay. What about medication, right? We do this to patients. So any AV node blockers can give you that, right? So you end up with sinus bradycardia, like beta blockers, calcium channel blockers like diltiazem, verapamil, okay? Digoxin can do that to you. What about tachycardia, sinus tachycardia? Who can drive your heart rate up?
Stress.
All right, stress. You're stressed up. You started your internship. You're stressed. Right.
Like any physical activity, like hot water.
All right, so if you make me now go from first floor to the 9th floor and tell me, Dr. Cruz, there's a code, there's a C, C, and 9B, and I'm going to run in my shoes from, because the elevator is not working, of course I'm going to get tachycardia. All right, what else? Hyperdynamic circulation. Anemia, like, right? Sepsis, hyperthyroidism. Okay, all right. Good. Just remember, if it's sinus tachycardia in response to something, you don't really have to do anything about it, just treat the underlying cause, all right? So you see a lot of people hypoxic, right? Feverish. These are the people in the ICU that they have sinus tachycardia up to 120, 140 as a presentation for early sepsis or whatever, septic shock, okay? So rhythm. All right, what can happen with the with the P wave, other than being tall or being bifid, being notched? What can happen to it?
Hidden P. Something P wave is hidden, or it can come.
No P wave.
No P wave. All right, so that's something to know about. No P waves. So let's talk about the scenario in which you see an EKG and you see this. All right, sinus rhythm so far, no sinus rhythm anymore. No sinus rhythm anymore. What has to happen here for this guy to survive? Escape. An escape rhythm.
Yeah.
So who can give you an escape rhythm? If you go back to the low part, all right, so who can give you an escape rhythm? You can have escape rhythm in the atria, right? So in the atria around the SA node that will pick up this. This is like a fail-safe mechanism, right, for us to stay alive. So this can pick up at the rate of 60 to 80, right? Around the SA node or below, whatever you want, okay? So this is the SA node. And this guy fails to fire, or there's a sinus exit block. Battery's done? Yeah.
Almost like it's red blinking. It's not.
Okay. Let it die out. When it dies out, we'll change. Okay? Alright, so what else? Well, you have the AV node, or the junction as they call it, that can fire at what rate? 40 to 60. Alright. And then you have your,
20 to 48.
there you go. Alright, so ventricular escape rhythm 20 to 40. Which one do you want to be safe? If I gave you, which escape rhythm do you prefer? You would go, you go one, right? You go with this one. You wouldn't go with this one. But I've seen enough old people